In general, when approaching a benign tumor, we have to ask ourselves what approach is going to first preserve patient function and lead to the ideal quality of life outcome, and then secondarily give us the best tumor control. In some cases that means tumor removal, but in other cases it means controlling growth of a tumor that is minimally or not symptomatic. And then, of course, there's symptomatic relief. Some of these tumors grow so large that there's mass effect and secondary complications, and sometimes something needs to be done to relieve that mass effect, whether it be removal of the tumor, shrinkage of the tumor, or some other symptomatic intervention. We've taken data, which usually is found in small case series published by single institutions, and disaggregating the data patient by patient and combining it into large series of several thousand patients. When we look over large populations, we see that actually some surprising factors lead to neurologic deterioration and trigger intervention. It's really not the size of the tumor at the time that it's discovered, but rather the growth rate. So what we found from these studies is that tumors that are growing by greater than 2.5 millimeters per year will ultimately lead to fairly rapid hearing loss and should trigger earlier intervention if hearing preservation is the goal. Tumors that are growing quite slowly, regardless of the size when we first identify them, can be observed and in many cases will not lead to very significant deterioration. And what we found is that at best case, hearing preservation after surgery is on the order of 50%. And there are certain factors that contribute to hearing loss associated with surgery, particularly large tumor size, greater than 1.5 centimeters in maximal dimension, as well as age over the age of 60. It didn't matter whether patients underwent subtotal resection or gross total resection. Hearing preservation rates were about the same. This means that even when surgeons are intentionally leaving tumor behind, we are not seeing any increased preservation and function. The morbidity, about 50% to hearing, exists with the decision to actually operate on the patient. Surgery also carries other risks. There are a number of secondary complications, wound complications, CSF leak, medical complications that are a possibility anytime we choose to operate. And the longer the operation, the bigger the operation, the risks go up. As an alternative to surgical resection, we have the option to radiate these patients. And in the modern era, we're primarily using stereotactic radiosurgery to treat vestibular schwannomas. We looked at our own data as well as some disaggregated studies from the literature, and we found that tumor control rates with radiosurgery are quite high, in excess of 94 or 95%. Overall hearing preservation rate, slightly better than what we see with surgery, 57%. Most importantly, radiosurgery rarely leads to facial nerve dysfunction. So in patients who receive radiosurgery in these large disaggregated studies, we see facial nerve preservation rates in excess of 95 to 96%, which is significantly better than what we see with surgical resection. Meaning that if facial nerve preservation is really a patient's goal, we have to consider radiosurgery as an option against surgery. This might lead us to ask the question, why ever operate on a patient? Why not radiate most patients? And in fact, the trend for small vestibular schwannomas has been primarily to observe or to radiate. Not every skull-based tumor is a radiosurgical target, particularly because radiosurgery does not make the tumor mass regress and does not treat mass-related symptoms, and because, given the size and the proximity of some of these tumors to vital neurologic and vascular structures, the fall-off from radiation creates too much associated morbidity. With regard to meningiomas, our goal, similar to vestibular schwannomas, is tumor control while minimizing morbidity. Old data from the 80s and 90s, as well as even older data from Simpson himself in the 50s, has led us to the conclusion that the more we can resect, the better the tumor control rate. And while that is true, not all meningiomas are completely resectable, especially at the skull base, where their dural attachments are in close contact with cranial nerves and important vascular structures that would lead to high morbidity with the gross total resection. If we look at surgical outcomes for skull-based meningiomas, we realize that the cranial nerve and other neurologic morbidity associated with gross total resection of many of these lesions is just unacceptable, especially for meningiomas in the cavernous sinus and in the petroclival region. Morbidity rates for new cranial nerve deficits as well as worsening of pre-existing deficits exceed 50 to 75%. And these surgeries are sometimes associated with mortality as high as 7 to 10% for difficult lesions. What if we could shrink these tumors down to the size and shape where they would become better radiosurgical targets?
Adaptive hybrid surgery offers the opportunity of combining the best of surgery with the best of radiosurgery to identify patients who would benefit from subtotal resections followed by radiation to facilitate not only long-term tumor control, but preservation of function.
This concept is not a new idea. It's what people have been doing in their own practices for over a decade, using some multimodal combination of surgery and radiosurgery. The way it works in practice is that surgeons will take these large tumors to the operating room and resect whatever they think they can safely remove and leave whatever they think will lead to the most surgically related morbidity, and then target whatever residual tumor there is with postoperative adjuvant radiosurgery. And if we look over the United States at neurosurgical practice patterns, we see, in fact, that that's what's happening. That when it comes to benign skull-based tumors, about 50% are treated primarily surgically, but about 50% are being treated with some combination of surgery and radiotherapy. And over time, this has been a trend that's growing. So back in 2000 and before, most people were attempting to achieve a gross total resection. Sometimes subtotal resection was achieved because of intraoperative surgical issues, did not allow further resection, but a planned subtotal resection was really a rare thing. And now in 2011, 2012, 2013, we see a lot more people are planning subtotal resection in order to reduce surgical morbidity and then treating with radiation or following the patient and treating them at recurrence progression. While this shift in practice pattern of using multimodality therapy, including a safe surgical resection followed by radiation, may seem intuitive to some people, the data that I discussed earlier clearly demonstrates that we're not very good at determining when our resection is sufficient and when it's safe. As we can see in most of those disaggregated studies, even patients who had a subtotal resection had similar outcomes with relation to cranial nerve morbidity and other neurologic morbidity as patients who had gross total resections. What that means is, although we do our best to try to determine when enough is enough, sometimes when striving to achieve the maximal safe surgical resection, we push the limits too far and cause morbidity even without achieving a gross total resection. As one of my mentors always said, 95% of the damage in skull-based surgery is done in removing the last 5% of the tumor. When you think that you can get just a little bit more safely, and once the damage is done, you can't go back. Practice trends have already moved to the direction of intentional subtotal resection followed by adjuvant radiotherapy or radiosurgery. However, if we plan this ahead of time to use a multimodality combination therapy, we can achieve ideal resections while leaving residual tumor that makes an ideal single fraction radiosurgical target.
I'm a firm believer in adaptive hybrid surgery and the multimodality approach to complex skull-based tumors, in particularly because I feel that it allows us to minimize the neurologic morbidity, particularly injury to cranial nerves from aggressive surgical resections, while still preserving and optimizing adjuvant radiosurgery plans so that radiation-related cognitive morbidity is also minimized. This results in superior local control outcomes to either modality alone, and also superior overall functional outcomes for the patients.